Hello everyone, welcome to White Coat Blueprint. I'm your host Sai, and I'm back again with another interesting interview. And joining me today is Dr. Meredith Sloan. She is a pulmonary and critical care physician at the University of Mississippi Medical Center, where she also serves as the Associate Fellowship Program Director, training future physicians. So, thank you, Dr. Sloan, for joining. How are you doing?
I'm doing well. Excited to be here.
Yeah, thank you. Thanks for taking the time to be here with us. I really appreciate it. So to get us started, Dr. Sloan, could you tell us what critical care medicine is? Because some people are not very familiar, and what makes it distinct from other areas like emergency medicine?
Yes, great question. So really the basics of critical care medicine is that we take care of patients who are in the ICU or the intensive care unit. And that usually means people who are on life support or who need a lot of extra monitoring because they're so sick. So it's kind of a special area in the hospital where we have nurses who are specially trained in critical care. They only have one or two patients, so they're really able to pay close attention and be on hand for the sickest of the sick patients. So we see patients who are on ventilators, who are on medicines to keep their blood pressure up, even some advanced forms of life support, like ECMO, which is extracorporeal membrane oxygenation. So we actually bypass their heart and lungs. So it's a tough place to be, obviously, really sick patients, but it is also an exciting place to be because lots of things are happening. You get to make lots of medical decisions. So every day is a little different in the ICU, which makes my job interesting.
Thanks for sharing that, Dr. Sloan. I think every time, I start an interview, I usually start with the very basics because I want my audience to know what really the specialty is about. And I think that's really important to, start with a clarification. So thank you so much for sharing that. And I'm just a little curious. You say that, your job's very exciting, even though it can be really hard for the patients and you're just trying to do your best for them and everything. So it just makes me curious. What really, attracted you towards this field of medicine? Because I just find it really fascinating. Every time I talk to doctors in my interviews in White Coat Blueprint, it just makes me wonder what really inspired them. And it's my favorite question to ask, actually, because every doctor has the story for them, right? It's like it's just a job that I'm talking about, but for them, it's an entire story, it's an entire experience. So I want to learn more about, what really made you choose pulmonology and critical care.
Yeah, so I always liked the math and sciences, and so I went to for my undergraduate degree. I actually studied engineering, because I like the problem solving aspect of it, and well, engineers super needed and a wonderful profession, but it just felt kind of dry to me without the kind of personal impact and interaction that you get. And so as I was kind of working through my degree, I decided that I'd rather be in medicine where I'd get to apply these skills, to people and have those kind of interactions and that gratification. So that's really what pushed me towards going into medicine. My father is an ophthalmologist, so I did have some of that example at home of what being a doctor could look like. So that also kind of, I think, helped shape my trajectory. And I haven't regretted it ever since. I love my job. I may dread waking up, but I never dread coming into work. So that makes every day a little bit easier for sure. 'Cause we do work a lot, but it's worth it.
Yeah. Well, I see that, you had this realization, when we were doing engineering, and it's just kind of interesting, how, it was a much needed realization, because like now you're really happy doing whatever you're doing, and, making impact in others' lives. So I think that's really rewarding, and you made a good decision, Dr. Sloan. I think you should feel very proud of yourself for that realization of yours. So yeah, keep it up. Keep, doing the great work that you're doing. And, there's always a lot to learn in medicine. That's what I say. The learning never stops.
Yeah,
So yeah,
lifelong
thank
learners
you.
for sure.
Yeah. So in pulmonology has evolved tremendously over the past few decades, and it's still rapidly growing, right? And not to mention, less than a decade ago, we had COVID-19 pandemic, and it was one of the most defining moments in modern medicine, and it put pulmonologists and critical care physicians in the spotlight. They were out there saving all those patients. The ICU, we don't even need to talk about it. Doesn't need a recap, right? It was absolutely terrifying, and I just want to, ask you, how was treating patients at that moment like? And you know that you're making a direct impact, and you're most needed than ever. So how does that feel like, Dr. Sloan?
So, I was finishing up my internal medicine residency. We had a couple months left in March of 2020 when COVID really hit, which everyone who does a subspecialty like cardiology or pulmonology does internal medicine first. So um, I I was a single lady and healthy, still I'm healthy, and single actually, but um, so um, I felt fine kind of venturing into the weeds and going to see these patients. We weren't as bad off as New York City, so we had masks even if we were reusing them some. And so I honestly felt, initially, although it was a little bit nerve-wracking to go see some of these patients we were suspecting had COVID, um, I felt like I was one of the best people who could go and see them. I wasn't bringing it home to anyone who was at risk, and I didn't feel like I was high risk myself and could protect myself pretty well. So, um, I volunteered and jumped right in and started seeing these patients as soon as they let us. um, and then actually I transitioned into a role called chief resident. So I was kind of helping run the residency program and still seeing some patients. So that was really interesting just because, as more and more information came out, we just had to make so many changes. We had our own residents who were getting sick at much higher levels than usual and having to, go out and be away from work for a week or more sometimes. And so that was an interesting challenge, just kind of rolling with all the constant changes that were happening in the healthcare system. And then after that year is when I started my fellowship in pulmonology critical care. And that's when the Delta wave hit, which was pretty bad in our area. And that's when I really got a first-hand look at the sickest of the sick from COVID. And it was, I mean, there's just some horrible stories, and people were out there denying that it was real. It was hard to listen to that because I was seeing these really, really horribly sick patients, dying patients in the hospital. Um, and I think if people had been out there denying that this pandemic was happening, no, no, there's nothing going on, I would have been the one screaming conspiracy because there's clearly something happening. This was not the norm. Because I had pregnant patients, young healthy patients. I had this poor elderly lady who, she'd done all the right things. She socially isolated. She got vaccinated. Um, and she finally let her unvaccinated son come to visit, and he gave her COVID, and she ended up in our ICU. And it was just, she was so upset and afraid, and it was just so hard to see all of that happening. It definitely took a toll. emotionally on everyone in the ICU. The nurses were seeing it day in and day out, and they were really struggling as well. So it was a tough time. And it was really good critical care training. They were very sick patients. Probably a better doctor because of it, but man, it was tough.
Oh my God. Actually, Dr. Sloan, I really like the way you put your words together and, explain things. COVID undeniably was awful. It was terrible for everybody, the lockdown, all the patients, the sick patients dying, all the sick people coming to hospitals and, losing your loved ones, obviously. It's not easy at all. But I really like the way you shared that experience. You were young and you were jolly and, you had all this energy inside you. And it's really nice to know, learn about that and, live it through your experience, how you experienced COVID. And it definitely wasn't easy for anyone, for the doctors, especially for patients, for absolutely no one. But I really like the way you, put your words together and share your experience. I really like that, Dr. Sloan. I really appreciate that. And thank you. Thank you for being there with your patients. And, but we made it. Yay. So it's 2026. It's over and we made it. And fingers crossed, um, nothing like that should ever happen again. So yeah, I mean, it was not easy.
This time it's a GI pandemic that's going on with
Yeah.
the cyclosporidis.
Yeah. So I just want to know, apart from like the ICU, the incubators, outside of the more intense care, what does day-to-day pulmonology, like pulmonary care actually look like? That what are some more common problems you see regularly that most people might think is not really a lung issue?
Yeah, so when I'm in clinic, just seeing patients, a lot of common things being common. We see COPD, which is, usually a smoking related lung disease, asthma, lots of asthma. Um, Probably one of the biggest referrals I see is something called or chronic cough, which that could, most common reason I actually see for that is acid reflux, which is not really a lung issue at all. And then my particular specialty in my practice is pulmonary hypertension, which is kind of the end stage of several diseases. So that can be heart related, it can be autoimmune related. And then we see a lot of like occupational lung diseases, patients who have been exposed to sandblasting, or around here we have several chicken plants, and so some of those bird antigens can actually cause lung disease. So we see a fair amount of that. And then interstitial lung diseases, which are usually some kind of inflammatory or scarring process that's going on in the lungs. So we see a huge variety of things, which makes it fun. It's another interesting aspect that I get to be a specialist in clinic, and then I get to go to the ICU and still see a whole breadth of medicine.
Thank you, Dr. Sloan. Thank you for sharing that. Yeah, I think it's really important for people to know what really the field is looking at, like as in what doctors commonly see. Asthma is commonly known. I think everybody understands asthma a little more, and it's very common in children, and adults are still facing asthma issues, and it's something that people are more aware of, and that's a great thing, right? And actually, I when I looked into your profile, I also saw your clinical interest in pulmonary hypertension, and I actually want to go a little bit deeper into that because, like, yeah, I think it's important for people to know about that as well. So, could you explain what it is and why is it challenging to diagnose pulmonary hypertension, and how does it differ from high blood pressure that people are more familiar with?
Yeah, so everyone's familiar with, the blood pressure that, is generated from our heart and in our arteries. And that comes from the left side of the heart, so it pumps blood to the whole body. And then our right side of the heart pumps blood into our lungs. So we do have a blood pressure inside of our lungs. It's usually much lower, because it doesn't have to go as far, It's only going through the lungs and picking up oxygen and then going to get pumped to the rest of the body. There are several different diseases that can cause this, but what can happen is those blood vessels in the lungs can get damaged. The vessels themselves can start to get thicker, which makes it harder for oxygen to get into the bloodstream, which is a problem, of course. And then eventually, if the pressure gets high enough, it can start to stress out that right side of the heart. And it is not nearly as strong as the left side of the heart because it only has to pump blood to the lungs. So it doesn't take very much to really put a lot of strain on that right side of the heart, which is what can make it dangerous besides just the low oxygen levels is that stress on the heart and it can cause it to fail. The problem is that the early symptoms of it are not very specific. The early symptoms are shortness of breath and fatigue, which can happen from many, many, many diseases. And the only way to find it that early is usually with an invasive procedure called a right heart catheterization. So, we have to kind of thread a catheter through their heart and lungs and measure their pressures. And since that's an invasive thing, a lot of times diagnosis gets delayed as people look for other things until it starts to affect the heart. In that case, you start to see some signs on, if you ultrasound their heart and things like that. But by then, a lot of damage has already been done. And so that's kind of been a big push in recent years is to find better ways to identify pulmonary hypertension early. The other thing is makes it difficult is it's difficult to treat. It's difficult to find medicines that are only going to affect the blood vessels in your lungs without causing other issues. But we've finally are getting some new medications on the market. There's been a lot of research in this area, so it's a really exciting time to be in pulmonary hypertension because there's some really good medications coming on the market for it. And then the last thing that makes it difficult is, like I said, there are multiple different things that can cause it. And as our patients, are living longer and getting older, may have multiple different risks. So they could have some heart disease that's causing it. They could have lung disease that's causing it, and that complicates the diagnosis and the treatment as well. So it's tough. These medicines are expensive. They have to come from specialty pharmacies. They need a lot of monitoring for side effects, and so a lot of people don't want to take it on in practice because they just it requires a little extra work. But I've been doing it for a little over a year now in my practice, and it is tough, but it's also really gratifying. I mean, these patients feel so short of breath, and to see them start feeling better and be able to do more and get around more is very gratifying. So, it's been a blessing to me to be able to take care of them and offer them that help.
That's so sweet. Thank you so much for all the work that you do, Dr. Sloan. I think that's incredible, caring for somebody who is out of breath and they're facing something that is really, really terrible, that results to organ failures. That's just really, that's not right. And to be able to help them is amazing, and it should be really gratifying for you, and it does sound like a blessing to me actually. So all the best to you, and I hope for the best for your patients, and I really hope that medicine improves to a great height one day, that the patients with pulmonary hypertension can get instant treatment and recover quickly and they can have the best results. So yeah, also I have another question. I'm just a little curious about a respiratory failure, like as in lung failures. So it sounds pretty clear cut out, right? So like as in when we say lung failure, we're talking about like how the lungs is not working properly. It's not doing what it's supposed to do, right? It's not filtering. It's not like purifying air for us. We're not able to breathe properly. That's what we think. But like, I want to know what really leads to lung failure. Like, when we say a person is having lung failure, what really like happens behind it?
Well, like with a lot of things, there are varying degrees of it, and most of us have more lung function than we need. And so you can have, some pretty significant disease of your lungs without necessarily going into respiratory failure. And so it can take a lot. Probably the most common population I see it in, my pulmonary hypertension patients, but also this group of diseases that cause interstitial lung disease, where, the actual tissue of the lungs, where oxygen's getting into the bloodstream is affected from scarring or inflammation. And so that lung tissue gets damaged. So usually the first step in respiratory failure is their oxygen levels drop and they're requiring oxygen. I have a lot of patients in my clinic who are on oxygen all the time. And then, eventually, it becomes harder for them to breathe carbon dioxide off as well. And, a lot of this is kind of disease and patient specific, but they may start with needing, um, extra support at night where they may wear a mask that gives them extra pressure. Non-invasive ventilation is what we call that. And then, sometimes if they have an acute episode on top of that, they may end up in our ICU, on one of those non-invasive or eventually an invasive ventilator where we put a tube down their windpipe and put them on the ventilator and help them breathe with the assistance of the ventilator. So there's a whole spectrum. Some people can recover from respiratory failure, and some people end up on ventilators long term and end up in nursing homes, on long term life support. So there's a whole spectrum of help you can give people in and out of the hospital to kind of help support their lungs.
Okay, okay. I think you highlighted something really important here. You spoke about how, people who have respiratory failure, most of the time they need to like go under severe care, like under a lot of care, and they need a lot of medications. So, and you also spoke about how, people who do recover they still face long-term impact on their lungs. So like, I think that's really important to know that, it's not easy to make a full recovery in pulmonology. Is that what you're trying to say? And I mean, like, has medicine advanced to a level that, patients can make a full recovery when it comes to lung failure or any disease in general? How is it, Dr. Sloan?
Yeah, it really depends on the cause. So if you have a pneumonia, a lot of times you'll regain a lot of that function. Your body's able to heal that. But there are some diseases when the damage is done, and we may be able to make you feel a little better, but particularly like the smoking related diseases, right? Patients who get emphysema in their lungs, that lung tissue is destroyed, it's gone, we really don't have any method of bringing that back as medicine stands, except for lung transplants. So, something like that. Again, we can improve their lung function a little bit with things like inhalers and make them feel better. But um, there's no real way to heal the emphysema. And similar to these interstitial lung diseases that I mentioned, a lot of them have, the body creates abnormal scarring in the lungs. And again, scar is scar. We can prevent it from getting worse with some of our medications, but it's really hard for us to undo that. Now, there's some diseases, particularly, our patients with autoimmune diseases, things like lupus and scleroderma and things like that. If there's a lot of inflammation in the lungs, we can reduce, undo some of that because it's still active and ongoing. So that those patients have more of a mix of damage done, but some that we can fix. So it's tough. It's tough. It depends. But yeah, some people make great recoveries especially from acute insults like pneumonia, but for some patients, it's a lifelong disease.
Thanks for sharing that, Dr. Sloan. I think you gave us like a deep insight into like what kind of diseases there are and how is the recovery process like and what really happens to the human body when the person is experiencing or fighting such diseases. So thanks for sharing that, Dr. Sloan. And I quickly want to jump back into what you do. You also train future pulmonologists, like as in you train future physicians, and could you tell us what that is like? And apart from, grades, education, what do you think will make an exceptional physician? Like when it comes to quality, what quality do you think that physicians require for them to be exceptional in what they do?
So, yes, I knew pretty early on in my training that I enjoyed teaching, and that I wanted to make it part of my career. And I'm so glad I did. It's also challenging, but in a great way. So, obviously I do some lectures and things like that, but the bulk of my teaching is really at the bedside with the patients and with the trainee, which makes it a lot of fun because it feels more like teamwork. Yes, I'm giving them my insight, but we're working together to make the patient better. I mean, they can come up with ideas and things that I haven't heard of, so they're always challenging me to be better as well. And so I really love that being in that atmosphere and being able to, give back. But honestly, they give as much to me as I could possibly give to them. So I do really love being in medical education. Um, and then what makes a good physician? I think it's a given. Anyone who gets into medical school has the brains for it. But I think really key things are making sure that you like what you're doing because if it's just something you're checklisting to get through the day, it's hard to be a good physician like that. You need to like and hopefully love what you do, and because everyone you see needs your help and needs your thoughtfulness. And it's just really easy on a bad day not to give your best for a patient, and that's not what they deserve. So why don't make sure that you love it and you know what you're getting into before you get too far down the path. And obviously having compassion and empathy for your patients is a big part of that. The other big thing, I think people don't realize until they really get into medicine is being a good communicator. I'm not just teaching my trainees, right? I have to teach my patients about their diseases, what I'm doing for them, why it's important, because I'm giving them medicines that have side effects or may have to be taken multiple times a day, um, and they may not feel better right away with it, right? And so, really talking them through all that, helping them understand what they can do for themselves and what the medicines are doing for them, and all, it can make a huge difference in their outcomes if they're invested in their care. And it's really easy to isolate a patient. I had a patient today describing to me all the doctors she's fired, and I was like, oh no.
Oh.
uh, you know, you know, and it sounds like for some pretty good reasons. Yeah, I can't entirely blame her, but being a doctor is tough. So having some of that love for the job to fall back on does help on your bad days. Um, so I'd say those are two big things that I'm really looking for. And of course, a love of learning really helps too, because things are constantly changing. So if you don't want to go and read some more about your specialty in your off hours, then it's pretty easy to fall behind.
Thanks, Dr. Sloan. You said a lot of important facts here, like love for your job, being passionate about what you do, and, just being a good listener and having compassion for your patients. You covered a lot of important values that a doctor should have, and I think I agree with you. I completely agree with you. And I see a lot of passion in you as well. I can see how much you love your job, and when you talk about it, you smile a lot. You just love doing your job. You're just so joyful and positive, which I love a lot. You're seriously a breath of fresh air, Dr. Sloan. Thank you so much for sharing your thoughts and everything. You've covered everything perfectly. And I have one last question for you. This is for high schoolers watching White Coat Blueprint. For those who want to explore a career in healthcare, do you have an advice for them?
Yes. So practical advice. I can give you practical advice and maybe a little less practical advice, but practical things I think you can do if you're interested in medicine. One is take science classes. That's gonna be a good basis for you in the future. And believe that you can get there because you can. It's a hard road. When you're in the middle of taking your MCATs in college and that kind of thing, it's very easy to feel discouraged, but you can get there. And you definitely won't know if you don't try. So I do want to encourage anyone who's interested, to try. Um, but I do think it's helpful if you have the opportunity to volunteer or shadow a doctor and just get a true idea of what the day-to-day looks like. I do think that's helpful before you dive into it because it's a big commitment going into medicine. And like I said, it does help to actually like what you do, like being around people. So I do think it's helpful. My less practical advice is don't be single-minded about it. Like when we're interviewing people, we want to see that you're a person too, that you have outside interests that you enjoy, that we can enjoy talking with you about, that can help replenish you when you've had long days. And so don't be afraid to pursue your other interests as well, which I know is easy for me to say and a lot harder to do. But yeah, you don't have to be single-minded about it. Only do, medicine all the time. Feel free to explore other things as well, and that makes you um, yeah, I think that makes you more well-rounded, which I know is sometimes not valued on applications, but it really is when you talk to people, when you talk to patients, when you talk to future coworkers, and all that kind of thing. So that's my advice.
Thanks, Dr. Sloan. Speaking of other interests, what are your interests and hobbies?
Yeah, so I have two golden retrievers.
Mm,
One of my favorite interests is hanging out with them on the couch, but we also like to explore different walks and things around town. I play a little golf. I feel like that's a classic doctor thing to say, but to be fair, my dad taught me far before I ever thought about being a doctor. So,
good.
I still get to get outside and enjoy doing that. So that's a couple of my hobbies. I still enjoy being a nerd and reading and all that kind of stuff too. Don't worry.
Thank you, Dr. Sloan. Thank you so much for sharing your hobbies and interests with us. It was so nice to have you here with us and, for you to share all your experiences, your thoughts, your advices for, high school students. And you are a teacher, a doctor, and a trainer, and you're a very interesting person because, like, you have all these jobs that you're doing and you love all of them equally. And it's so nice to see that. I wish the best outcome for all your patients and continue to do the great work that you're doing. And thank you so much for being here. See
Well, it's
you.
my pleasure. It's so much fun talking to you.